Assalamu alaikum everyone. The next topic of discussion is syphilis, which is a sexually transmitted disease usually caused by Treponema pallidum, and it has four stages. We have primary, then we have secondary, then we have a dormant or latent phase, and then we have tertiary phase. It is usually more common in male as compared to female, 8 times more common, and its peak incidence is usually between 25 and 29 years of age. What is the underlying cause? So Treponema pallidum causes Syphillis, which is a gram-negative spiral-shaped bacteria belonging to the spirochete family. Its transmission is usually through sexual contact. Can also occur vertical transmission from the mother to the baby, and also through blood transfusion or organ donation, which is rare. Treponema is highly contagious during stage 1 and 2. What is the underlying pathogenesis? So spirochetes invade the body, disseminate systemically within hours, bind to endothelial cell, inflammatory reaction occur, and it leads to endarteritis and perivascular inflammatory infiltrates. What will be the clinical features? So the incubation period is in the range of 10 to 90 days, and on average it has 21 days of the incubation period. Primary syphilis. So in primary syphilis, it's a localized disease. 90 to 95% we have genital primary syphilis, and 5 to 10% it's extragenital. Most commonly involve the oral cavity. Also involve the finger and anus or perianal region. In primary syphilis, we have lesions known as primary lesions called chancres, which are usually solitary raised papules, and these are usually on the genitals. These evolve into painless firm ulcer with indurated border and smooth base, and they resolve spontaneously within 3 to 6 weeks without scarring. Then we have non-tender regional lymphadenopathy in the primary syphilis, and involvement of the inguinal lymph node in the genital primary syphilis occurs. So we will have painless ulcers, chancres, and non-tender regional lymphadenopathy. In secondary syphilis, so it's a disseminated disease due to the systemic spread of the spirochetes inducing an immunologic reaction. It begins approximately 2 to 12 weeks after the primary infection and typically lasts 2 to 6 weeks. So start 2 to 12 weeks after the primary infection and last for 2 to 6 weeks. What are the symptoms? So there will be constitutional symptoms like generalized non-tender lymphadenopathy. Remember, lymphadenopathy will be non-tender. Fever, fatigue, myalgia, headache. Then we will have polymorphic rash in the secondary syphilis, which typically disseminated non-pruritic, macular or papular rash involve the trunk and extremities, also the palms and soles. It is reddish brown or copper colored and heals within 6 months. Then we have condyloma lata, which is broad-based wart-like, smooth white papular erosion. It is also painless and located on the anogenital regions, intraterraneous fold, and on oral mucosa. So in secondary syphilis, we have constitutional symptom, we have polymorphic rash, we have condyloma lata, and then we have additional lesions like patchy alopecia, which is moth-eaten alopecia. We have sore throat like acute syphilitic tonsillitis. Then we have a special variant of secondary syphilis known as malignant syphilis, which occur in the setting of underlying immunosuppressions, and there will be multiple necrotic ulcerations. Remember that secondary syphilis causes systemic symptom, while primary syphilis is usually cause localized disease. This is the image which shows rash, polymorphic maculopapular rash in the syphilis. And this is another image which also shows maculopapular rash in the syphilis. And this is another image. And this is the image showing alopecia and secondary syphilis. In the third stage is latent stage of the syphilis. There will be no symptom despite seropositivity. May last months, years, or even for the entire life. Disease may resolve, reactivate, or progress to tertiary stage. And we have early latent and late latent. Early latent is acquired within the last year, and late latent is the stage that is acquired for greater than 1 year ago. Then we have tertiary syphilis. So in tertiary syphilis, we have gomas. These are chronic destructive granulomatous lesion with a necrotic center. They tend to ulcerate, may affect any organ, for example, skin, internal organs, and bones. This is the example that show facial gumas in the tertiary syphilis. Then we have a cardiovascular complication of the syphilis that lead to aortitis, inflammation of the aorta, ascending aortic aneurysm, dilation of the aorta, syphilitic mesoaortitis, and aortic root dilation and insufficiency. So syphilis leads to aortic root dilatation, leading to aortic regurgitation. Due to treponema-induced vasculitis of the vasovasorum of the large vessel, especially of the aorta, result in the vessel wall atrophy and thereby dilation of the vessel, leading to the formation of aneurysms. Then we have subtypes of the syphilis. So first type is neurosyphilis. Its neurosyphilis is infection with treponema invasion of the CNS, meninges, cerebral vasculature, and parenchyma. Diagnosis is based on characteristic clinical feature in conjunction with CSF finding. So it occurs usually in 8% of the infected individuals and more common in immunosuppression. Clinical features, so these are highly variable. Acute syphilitic meningitis, there will be neck stiffness, nausea, and subacute stroke, meningitis, and or cranial nerve disorder. Peritic neurosyphilis, chronic progressive meningoencephalitis resulting in widespread cerebral atrophy and major neurocognitive disorder. So there will be early manifestation include personality changes and deficits of memory and judgment can cause neurologic symptoms including dysarthria, hypotonia, and tremors. Then we have Argyll-Robertson pupil, which is bilateral meiosis, and pupil accommodate but do not react to direct or indirect light. This is the image showing Argyll-Robertson people. So in Argyll-Robertson people accommodation reflex present. So remember that in Argyll-Robertson people accommodation reflex is present. Like when you bring the something near to the eye, so there will be accommodation reflex. The eyes will accommodate, and rapid pupil constriction will occur. While pupillary light reflex will be absent in Argyll-Robertson people. This is the image showing wart-like lesion on the glans penis known as condyloma lata. Other type is condyloma acuminata, which is caused by HPV, human papilloma virus, while condyloma lata is caused by syphilis. And these are the primary lesions known as chancres on the glans penis. Now we have another complication of the syphilis known as staph dorsalis, which is known as syphilitic myelopathy, which is demyelination of the dorsal column and dorsal root ganglia, leads to impaired proprioception due to involvement of the dorsal column. So there will be progressive sensory broad-based ataxia, absent deep tendon reflexes due to dorsal root ganglia involvement, and there will be dysesthesia, loss of sensation predominantly in the lower extremities, and there will be sharp shooting pain in the legs and abdomen. There will be Charcot joints as well. How you will diagnose? So CSF study must be interpreted. So on CSF you will have positive VDRL test and elevated WBC count greater than 5 in HIV negative and greater than 20 in HIV positive patient, elevated protein and positive fluorescence treponemal antibody absorption test. How you will treat the patient? So treatment is penicillin. Patient with syphilis but without neurosyphilis can have unexplained CSF abnormality. In patient with clinical feature of neurosyphilis, a reactive CSF VDRL strongly support the diagnosis. Otherwise, otosyphilis infection affecting the cochlear-vestibular system and clinical feature will be tinnitus, vertigo, and sensorineural hearing loss, unilateral or bilateral. Then we have ocular syphilis, so it will lead to clinical feature, for example, eye pain, redness, flutter, light sensitivity, blur vision, and or permanent vision loss. So usually leads to panuveitis. And then we have another complication which is syphilis during pregnancy. How you will diagnose the syphilis? So if lesion are present, so order direct detection. Order both non-treponemal test and treponemal test for patient with clinical features and patient who meet the criteria for screening. Consider additional, for example, lumbar puncture based on the clinical assessment. First, we have direct detection. So, what are the indication? The presence of a rash or lesions consistent with syphilis. So, you will have to do the direct detection. Method. So detection requires specialized lab equipment since pallidum cannot be cultivated in vitro or visualized with light microscopy. So for this we have dark field microscopy for direct detection, visualization of the motile spirochete on wet mount under a dark field microscope. Then we have direct fluorescent antibody test for treponema, which is visualization of immunofluorescent antibody, and then we have PCR and immunohistopathology. So accuracy, so it's a gold standard to detect primary and secondary, but mainly for the primary we use direct detection. It says high specificity but non-sensitive. Like if it comes positive, so it means that you have the disease, but if it comes negative, so it doesn't mean that you don't have the disease. You have to do further investigations. If we have serological studies, so they can miss early primary syphilis as antibodies do not develop until 1 to 4 weeks after the lesions. And syphilitic algorithm is used which combine non-treponemal and treponemal tests. When interpreting results, be aware that serologic testing may remain positive in patients previously treated for syphilis. We have non-treponemal tests, so indication are initial screening, monitoring response to the treatment, and assessing for reinfection. Mechanism, so quantitative detection of antibody against the lipidal antigen, for example, cardiolipin. And there are two types of tests, RPR and VDRL. RPR is most commonly used, VDRL often used in the evaluation of CSA for neurosyphilis. They are highly sensitive but not specific, and false positive and false negative result can also occur. And these are the conditions during which these can occur. So remember, entity titer can undergo seroconversion and convert to negative even if syphilis is not treated. And another condition that after treatment entity titers can remain elevated despite treatment, which is known as serophosphate. False positive result on VDRL. This is the mnemonic. So P with pregnancy, V with viral infection, D with drugs, R with rheumatic fever, and L with leprosy. Then we have treponemal tests. So indication are initial screening and used as a confirmatory test in the testing algorithm. Mechanism is qualitative detection of antibody to treponemal antigens. So we have common example of treponemal test are FTA, ABS, TPPA, and IgG, IgM immunoassay. These have high sensitivity and specificity, and false positive and negative result can also occur. Algorithm, so either standard algorithm in which we first do entity and then TT, or reverse algorithm can be used. If the initial test is positive, so both require an additional test to confirm the diagnosis. If both the test positive, so current or past infection is likely. If the patient is previously treated, so consider reinfection. And if the patient had not taken treatment previously, so it most probably it should be active infection. Second test comes negative, so next step vary based on the algorithm. If the initial test is either algorithm is negative, so and the patient are low risk patient, so syphilis is unlikely. If the patient are high risk patient, so early primary syphilis cannot be excluded. Offer presumptive treatment if declined, repeat testing. What is the standard algorithm? So initial we have entity. If it come positive, so we perform a TT. If the entity is negative, so further depend on the risk status. Second test we have TT. If it comes positive, so current or past infection is likely. If it comes negative, so false positive entity likely. If risk factor are present, so repeat after 2 to 4 weeks. Or if follow-up is unlikely, so consider treatment. And these are the additional tests that can also be performed. Imaging can also be done like for cardiovascular syphilis, initial study CT or MRI of the chest. If inconclusive, so angiography can also be done. What will be the treatment approach? So initiate antibiotic treatment in patient with confirmed syphilis and suspected early infection prior to seroconversion, having history of sexual contact with a person with syphilis. So all sexual contacts of the patient with syphilis should be identified, evaluated, and treated. What will be the antibiotic therapy? So penicillin G is the first line therapy for all patients. Patient having confirmed penicillin allergy and having neurosyphilis, ocular syphilis, otosyphilis, and are pregnant. So initiate allergen desensitization and treat with penicillin. For all other, consider doxycycline or ceftriaxone who have penicillin allergy. If neurosyphilis suspected, so perform lumbar puncture and CSF analysis before starting the treatment. And these are some of the complications: Jerish-Herxheimer reactions and chorioretinitis.